Hello and good evening, everyone. Welcome to EUROGEN's webinar programme. It's really great that you've all been able to join us this evening. So just before we kick off, I'll just say a few brief words about the European Reference Networks, who we are and what we do. And this is the second webinar actually that is delivered jointly with two other European reference networks, ITHACA and ERKNet. So EUROGEN is one of the 24 reference networks that were created in 2017 by the European Commission, and they all deal with patients with rare diseases or complex conditions that require highly specialised healthcare. So in EUROGEN's case, we're a network of departments of highly specialised surgeons and their teams. And some of the ERN activities, well, we all have virtual consultations using a tool provided by the European Commission, which allows completely safe cross-border virtual consultations with our experts. And this service is free to any healthcare professional in the EU who would like advice on a particularly rare or complex case. Please feel free to get in touch with any of the ERNs with your tricky cases. We also have training and education activities like the webinar series, and we also have a clinical exchange program. So we have visits going between clinicians across our healthcare providers. And we also have a patient registry. Well, all ERNs have patient registries. So again, we hope that that will be very, very valuable for future research activities of the ERNs. And we also produce clinical guidelines together. So without further ado, I'd like to introduce the speakers of this evening's webinar. And I'm delighted to say that there's 4 of them because, of course, this is a cross-ERN collaboration. So first we have Damien Sanlaville, and he's from ITHACA, the ERN that deals with rare congenital intellectual disabilities. And we also have Bruno Ranchin, who is from ERKNet, which deals with rare kidney disorders. And he's from the Pediatric Nephrology Department in the Femme Mère Hospital in Lyon. And then for EUROGEN, we have Dr. Giovanni Mosiello, and he's a pediatric urological surgeon at the Pediatric Hospital Bambino Gesu in Rome. And then finally, we have Dr. Annalisa Scopinaro, and she is, of course, thanks Annalisa for coming again to our webinar series. She's, of course, with the Italian Federation of Rare Diseases, and it's really important that we have the patient view as well alongside that of the clinical experts. So that's all from me, and I very much hope you enjoy this evening's webinar. So I'll move over now, and hopefully Darren will smoothly transition to the presentations.
Good evening. My name is Damien Sanlaville. I am a geneticist, head of the genetics department at the University Hospital of Lyon, member of 2021 Research Society, and vice president of 2021 France. I would like to thank the organizer for inviting me to this second webinar. 2021, or Down syndrome, is a chromosomal abnormality in which all of or part of an extra chromosome 21 is present. Down syndrome has probably existed since the beginning of the humanity, as shown on this statue on the right. The first clinical descriptions were made by Esquivel, Seguin, then Down in 1846, who gave his name to this syndrome. Chromosomal etiology of the syndrome was identified in 1959 by Lejeune, Gauthier, and Turpin. De Graaf et al. In 2021 published an article on the estimated number of people with Down syndrome. They estimated that in 2015 there were about 400,000 people in Europe and 8 million in the world with Down syndrome, with a prevalence of 1 in 700 to 1 in 1,000 live births. Down syndrome is the most common neurogenetic syndrome associated with intellectual disability in the world. Currently, the diagnosis is most often made in the antenatal period, either as a result of biological or ultrasound screening. After birth, the main clinical feature is facial dysmorphism, as shown on the right of the slide, axial hypotonia, congenital hair defect, in particular atrioventricular septal defect in about 50% of patients, but also malformations of the digestive tract, congenital cataract, delayed psychomotor development, motorized intellectual disability, short stature. Patients with Down syndrome are frequently predisposed to a number of early onset complications, such as hearing impairment, infection including immunity infections, autoimmune and endocrine disease, such as diabetes, hair loss, gluten intolerance, orthopedic pathologies, postnatal leukemia, in particular acute lymphoid leukemia or acute myeloid leukemia, seizure with West syndrome, sleep apnea syndrome, and for the adults, early onset Alzheimer's disease and early aging. Alexander et al. Published in 2016 a study about morbidity and medications in large populations of individuals with Down syndrome compared to the general population. The aim of this study was to describe the incidence of morbidities and the prevalence of medical predispositions in a large Down syndrome population. More than 6,000 people with Down syndrome and more than 19,000 controls were included in this study. You can see here some of the results of this study with, unsurprisingly, a very increased risk for Down syndrome patients for intellectual disability, congenital or defect, seizures, hypothyroidism, but also less anxiety. If you are interested, more targeted studies were then published about these results. In these articles, in adults, there is a clear increase in the incidence of epilepsy and dementia, as shown in this part of the slide. Why a long-term clinical follow-up is necessary for patients in Down syndrome? Because the life expectancy of a person with Down syndrome is now estimated to be 16 years in the 2019. Follow-up of Down syndrome persons should be carried out annually at an expert reference center that has the specialties required for multidisciplinary care. People with Down syndrome are prematurely aged. In addition to the epilepsy and dementia already mentioned, one should look in particular for neurosensorial complications, sleep apnea, and metabolic disorder. About social life, Down syndrome persons are confronted with the end of life of their parents, and decisions about their care must be sufficiently anticipated. In the French National Diagnostic and Care Protocols, will soon be translated in English and available on the ITHACA website, we propose clinical follow-up and imaging examination follow-up, including cardiac ultrasound at age of 20 to check valve and after every 5 years. We also propose biological examinations follow-up, summarized in this table. In 2021, Hendricks will point out that life expectancy for people with Down syndrome has increased significantly in recent decades thanks to advances in medical care, but many scientific gaps remain that prevent further advances in the discovery of the new treatments and improvements in quality of life. Finally, a few words about treatments to make the link with scientific news. A little more than 15 days ago, Manfredi Lozano published in the Science journal a treatment to improve the cognitive ability of patients with trisomy 21. Many treatments are effective in mice, but few in humans. And I think we must wait for a randomized double-blind clinical trials to conclude about the effect of this treatment. I would like to thank you for your attention, and I am available for any questions.
Good evening. First of all, I would like to thank the organizer for inviting me to talk about renal involvement in Down syndrome. I have no conflict of interest to declare. Is there an increased risk of renal involvement in persons with Down syndrome? According to the American guidelines, routine postnatal renal screening is not recommended. Patients with Down syndrome are at a risk for multi-organ dysfunction, which requires extensive medical supervision and results in a high disease burden during infancy and childhood. Thus, each screening must be justified. We have some data to argue for kidney screening in some patients. One study has shown that congenital renal and urinary tract anomalies are 4.5 times more common in US children with Down syndrome than in the general pediatric population. In another study conducted in Western Australia, the rate of hospitalization for kidney and or genitourinary diagnosis was 5 times higher in children with Down syndrome than in the general population of the same age, with a median follow-up of 12.5 years. Creatinine is produced by the muscles and eliminated by the renal glomeruli. Serum creatinine is a biological marker used in clinical practice to assess the glomerular filtration rate. It is higher in case of glomerular dysfunction and lower in case of lower muscle mass. Mean serum creatinine is slightly higher in children with Down syndrome than in the general pediatric population, as shown in this nice study in Japanese children with Down syndrome, after excluding children with a known disease that affects glomerular function or muscle mass. You can see from these two graphs that mean serum creatinine plotted against 8 is indeed slightly higher in children with Down syndrome than in control children, in both boys and girls. You can see the curve of children with Down syndrome and the curve of control children. That's the curve of girls. In the absence of an increased mean muscle mass, this is a sign of decreased average kidney function in children with Down syndrome. This should not scare parents. This probable slight decrease in mean glomerular function in Down syndrome children is completely asymptomatic and does not represent any short-term risk in most children. But, in my opinion, this justifies the identification by medical teams of children at risk of decline in kidney function. In these children, identification of associated renal risk factors is necessary to prevent further deterioration of renal function. Glomerular filtration rate can be estimated using formulas established in the general pediatric population. The most used include 8 and serum creatinine in the international formula, plus gender in the Japanese formula. These serum creatinine formulas are probably not suitable for children with Down syndrome. This is due to the different growth rate, onset of puberty, and lean mass in children with Down syndrome compared to the general population. Cystatin C is another marker of glomerular filtration rate. It is independent of muscle mass, but dependent on serum thyroid hormone levels. It has been used in few children with Down syndrome in one study. Serum cystatin formula should not be used in uncompensated thyroid dysfunction. The measurement of creatinine clearance by timed urine sampling has been performed in a few patients during all the studies. The measurements were not normalized according to body surface area and therefore cannot be used. There are no studies reporting the measurement of glomerular filtration rate in Down syndrome persons using gold standard techniques as inulin clearance. Keeping in mind the limitations of serum creatinine-based formulas for assessing glomerular filtration rate, estimated glomerular filtration rate has been studied in 2 recent cohorts of children with Down syndrome. Normal estimated glomerular filtration rate in children is greater than 100. In a cross-sectional study of 69 Spanish children, 3 of them showed a marked decrease in glomerular filtration rate, estimated between 50 and 60. In another cross-sectional study of 108 Japanese children, from which children at risk of renal dysfunction and low muscle mass were excluded, the estimated mean glomerular filtration rate was 91, which corresponds to 80% of the mean value measured in a control population of the same age. Isolated cases of end-stage kidney disease have been published in patients with Down syndrome. Acquired glomerulopathies seems as frequent as in the general population. In the event of an evocative clinical picture, the same investigation as in the general population must be carried out. Kidney size has been studied in 49 Belgian children with Down syndrome and at a mean age of 8 years. It was smaller than in age and sex-matched controls, and this difference does not seem to be due to smaller corporeal height. Asymptomatic hyperuricemia seems more frequent in patients with Down syndrome. Some studies showing a higher prevalence in Down syndrome patients were published in the 60s and 70s. More recently, hyperuricemia has been reported in 12 to 33% of children or young adults with Down syndrome. It was more common in boys. The pathophysiology of hyperuricemia is discussed. 2 authors have shown a decrease in the renal elimination of uric acid, and a 3rd study showed that the metabolism of purines seems to be increased in patients with Down syndrome. The significance of this hyperuricemia is discussed, and again, this should not scare parents. Indeed, all the children were asymptomatic, and hyperuricemia is benign in the short term, but could be associated with an increased cardiovascular and renal risk in the long term. This hyperuricemia does not justify any drug treatment, but must encourage the promotion of a healthy diet and lifestyle. The literature, therefore, reports a probable slight decrease in average kidney function in people with Down syndrome. The reasons for such a decrease are probably multiple. First, congenital, renal, and urological anomalies seem 4.5 times more frequent in Down syndrome than in the general population. Regarding renal malformations, cystic dysplastic kidney and renal agenesis seem to be more frequent. Second, some kidney dysfunctions may be due to the late consequences of prematurity, which is observed in 9 to 24% of Down syndrome patients, intrauterine growth retardation and or low birth weight reported in 20% of patients, and last, congenital heart disease reported in 44% of patients. All these comorbidities are associated with an increased risk of delayed kidney function and justify long-term renal monitoring. Third, some decreased kidney functions may be due to lower urinary tract dysfunctions that are also common in Down syndrome. How to identify children at risk? First, thanks to prenatal ultrasound. Secondly, thanks to renal monitoring of children at risk, born prematurely with low birth weight and or congenital heart disease. And last, through screening for lower urinary tract dysfunction. In summary, there is a probably increased risk of kidney dysfunction in people with Down syndrome. This increased risk is caused by more frequent congenital renal and urological anomalies, more frequent comorbidities associated with delayed kidney function, and more frequent lower urinary tract dysfunction. It is not justified to carry out systematic general screening other than prenatal ultrasound, but there is a need for regular follow-up in the event of comorbidity associated with the risk of delayed kidney function. In such cases, we can propose annual blood pressure measurement, proteinuria screening, and serum creatinine dosage. There is also the need for prevention, screening, and treatment of lower urinary tract dysfunctions. Thank you for your attention, and I will be happy to answer your questions.
Good afternoon to all. Thanks to be there for this webinar. I'm Giovanni Mosiello, and I will go to present the urogenital aspect in trisomy 21 Down syndrome. The trisomy 21 Down syndrome is one of the most common severe unemployed conditions at the time of the birth, and is very important for this reason. As we know, is considered a rare disease, and we have some typical clinical features that affect with potential malformation and complication several organs. And respiratory infection is the most common reason of death in childhood, while dementia is the reason of death in older people. Today, the average life expectancy for persons with Down syndrome is rising from 25 years to 60 years. And today, the involvement in community life has become increasingly important as persons with Down syndrome survive longer and achieve greater degrees of independence. Renal and urological anomalies have been reported to and include renal agenesia, hydronephrosis, ureteropelvic junction obstruction, posterior rectal valves, hypospadias. The incidence of these anomalies varies from 3.5 to 21.4%. Furthermore, we have to consider, as urologists, continence issues in quality of life. Considering the literature, one of the most important review for me is this paper of the French colleagues that are present to this webinar, and they collected papers from 1995 to 2015, reporting the different anomalies of urogenital tract present in the different experience. Contributing factors they define furthermore are very important because they reported as a cause of acute kidney failure, bilateral lesion and minor renal injury related to glomerular microcystis, tubular dilation, and immature glomeruli. Furthermore, they describe the two metabolic specificities that are present in this population as decreased clearance of uric acid and hypercalciuria that could be very important for stone formation. Their conclusion is a suggestion that could be very important to have a monitoring of this population with repeated renal ultrasound, control of arterial pressure, control of the proteinuria, and the renal function. Other interesting paper is this paper of the group of Barth describing bladder and bowel dysfunction. They reported different experience with a high percentage of bladder and bowel dysfunction in children with Down syndrome. They suggested, furthermore, a flow chart how to follow and how to study this patient, the role of invasive and non-invasive urodynamics study, the role of renography, and for the bowel, the importance in some selected cases of rectal biopsy. And they suggested also conservative management and medical management with drugs for both situations. They recommended a close follow-up of the population and the importance of clean intermittent catheterization in presence of bladder dysfunction and the relevance of surgery procedure in selected cases where clean intermittent catheterization is not possible. In this diagram, we can see reported the different experience. The ICI recently focused again the relevance of the children with special needs, the prevalence of LUTS in this population, identified a 27% of incidence in Down syndrome, incidence that is decreasing with age. The screening is important for selected patients with LUTS, where a delayed achievement of continence is reported, a delayed age of initial interest in toilet training is reported, a longer duration toilet training is reported, and at the age of 5, only 79% of children with Down syndrome were found to be toilet trained. Again, the suggestion of our committee of ICI, Pediatric ICI Committee, is a conservative management, the relevance of urotherapy, and the surgery that could be useful in selected cases. Why could be useful surgery in selected cases? Because we can observe in some patients a non-neurogenic neurogenic bladder where there is an high risk of end-stage renal disease. And this is true for males, but it's true also for females, as reported in other paper. One of the points that could be critical in this patient is the urethra in male patients, and there is a high risk for urethral malformation and for posterior urethral valves. And this case report of the group of Massimo Garripoli is very interesting because they stressed how there is no recommendation by the UK group and the American Academy of Pediatrics for the supervision for children with Down syndrome. That they recommend, of course, in selected cases, but they stressed the importance to have a ultrasound and the monitoring of patient and the request for visiting in case of poor urinary flow. Other paper very interesting is this of the group of Mercer that recommend circumcision in male boy and the monitoring for clitorchidism, the regular screening of bladder and renal ultrasound, and in selected cases, of course, the opportunity to perform more invasive study. It's very important the management of this patient in the case of anesthesia, and I stressed the importance to check for cardiac disease and the presence of atlantoaxial instability that could be a cause of difficulties for tracheal intubation, and the presence in high percentage of infraglottic stenosis, the large tongue, and the risk of post-intubation crew. Other issues in this patient to consider as a pediatric urologist is the fertility, either in men and in women, with all the aspects that we have to consider. But it's important to know that there is a reduced fertility in male. Only 3 cases post-anal conception have been described in literature. And maybe this is due to a low number of patients sexually active or wishing to have children, and also to the high risk for gonadal dysfunction that is observed during time. On the other side, fertility in women is reported, but there is a high early menopause in women with Down syndrome. Of course, this could be very important to know for the family, in order to help the selected population of patients with Down syndrome that require. And the other point to consider is the risk for cancer risk. And there is an increased risk for developing certain tumor as acute leukemia, germ cell tumor, testicular tumors, and reduced for other ones as neuroblastoma, Wilms tumor, and breast cancer. And this is confirmed by another paper. And the suggestion is especially for annual surveillance for testicular cancer. So in conclusion, if we check to the European Society of Pediatric Urology, European Association of Urology, we don't have specific guidelines and best practice recommendation for children and adults with Down syndrome. For this could be useful to define a common approach as best practice recommendation for major issues regarding testicular cancer screening, bladder dysfunction diagnosis management, calculus diagnosis and management, genitalia screening and management, considering also the fertility aspect. Thank you very much. Someone that would like to join to this group, and please write to me. Thanks for your attention.
Hello, everybody. Thank you for this invitation. And I tried to share my slides. Okay, I think just a minute. Okay, you asked me to bring the point of view of patients in this webinar regarding Down syndrome. So first of all, I have to declare that I have no conflict of interest. And something about me, I'm Annalisa Scopinaro, and I am an EPAG representative in ERN ITHACA. And I am also the president of UNIAMO. And UNIAMO is the Italian Federation of Rare Disease, the National Alliance of Urologists. We are part of the National Council of Alliances in Urologists. We have about 107 associations inside UNIAMO, and we represent in Italy the community of over 2 million persons that lives with a rare disease in our country. About Down syndrome associations, there are a lot of Down syndrome associations all around Europe, all around the world, I must say. Oh, sorry. And a lot of them offer services, medical suggestions, solutions for improving the abilities of the people with Down syndrome. So one of the best things to do when you discover a person, you diagnose a person with Down syndrome, is to find one of the associations and tell them to go there to have support and to afford the life that they will have to live from that moment to the end of from that moment to and go on. What are the needs of people with Down syndrome? First of all, of course, a periodic follow-up to monitor the clinical situation of the person that has Down syndrome. And this follow-up should include, among the others, mental health specialists, gynecologists and urologists that are sometimes forgotten, and geriatricians. It is important also to guarantee the traditional care. While checking and stabilizing the clinical situation, we need other things, and such as school and teaching support to accompany the person on the learning path, educational support to develop personal skills of self-managing, work training and tutor support to learn how to approach a job and to interact with the colleagues. This is very important if you want to assure a job to a people that has this kind of difficulties. And of course, we need specialized centers. And an example of this is rehabilitation centers to develop and improve personal skills with physiotherapists, psychomotricists, and all the people that can improve the skills of a person. And this could last for all the lifelong. So we have to have these rehabilitation centers for all the ages. We need also daytime relief centers for those with fewer abilities, and retirement homes for the eldest, but is important too. And the families could need economic supports because the expenses with a person with a daughter or a son with a special needs could be very heavy to afford. So it is important to have economic support from the state just to cover, for example, the expenses of therapies that are not paid in the most of the time by the public health system, to cover the expenses of the paths of autonomy, tutors, and caregivers. It could be helpful to have tax reliefs. In Italy, we have a special law that allow the people to have tax reliefs if they invest in the future of their son or daughter. Some supports should be guaranteed from the state. For example, a house where to live when they are in the major age, or a tutor, a caregiver. About sport and spare time, people with Down syndrome, as all the people, need to be included in sport activities. In our experience, one of the best choice for this is to join Special Olympics, but is an international association founded in the USA, which was created especially for people with intellectual disability. It was a great intuition of Lady Roosevelt that wanted to assure a path to people that has this kind of issues. And it is very important because all the boys and girls that are involved in Special Olympics game are so proud to be athletes and to be as the others, to have the chance to practice a sport. One of the most important questions for parents is a standing alone life possible? It is impossible to give an answer, but is the same for all the people. The variation of phenotypic characteristic could be wider, so it is not really possible to think about a standard behavior. There are a lot of examples, indeed, of people with Down syndrome that have reached good skills of autonomy, and they can live, if not alone, but in a protected situation that can help them to be alone, to feel alone. It is important to reach this kind of goal, to work since the first years of age on the ability, focusing on what is necessary to have the capability to manage a day-to-day life. It's really important. All the aspects of the life should be improved, and all the skills should be under stressed to assure to reach the most plenty of significance life. And sorry, the last diapo was not mine, but of course, I would like to say to you that it's important a clinician pathway, but also a social pathway that can help families and the people with Down syndrome to live at the best their lives. So thank you for your attention, and I beg your pardon for my bad English and for some mistakes I have done during my speech, but I must say I'm also very tired, and so English is worse than ever. Thank you a lot again for this invitation and for your attention, and to invite me in this webinar. Thank you.
Okay, that concludes all of the presentations. So maybe I could ask the presenters to all put their cameras on and put their microphones back on. Hoping they're all still there, haven't run off.
Hey.
There we go.
Yeah, again. Well, thank you very much for your participation, and for me it's been very useful to receive input and knowledge by different specialists, and thanks Annalisa for your suggestion in how to improve the life of people with Down syndrome. That one point that you stressed was very important in my opinion, because as sometimes we do as mistake, we put many individual singular man, woman with an etiquette, with a name, but each one of them, and especially for Down syndrome, we have a situation completely different, where we can have, as I've seen in many years of my experience, a severe mental impairment, but on the other hand, we have people with a QI that is close many other people, and so their expectation for a normal life, for inclusion, that could be for a family, that could be for a work, a job activity, and as of course higher. And I don't know what is your opinion, but especially for the aspect of the urogenital and renal aspect, renal function, and I haven't not found any suggestions specific for this population, and I would like to invite the French colleague that I've seen that they fantastic work, because it was very interesting for me, and I can confirm that it was on the most interesting paper that have been written on this aspect. And if you like, if you agree to contribute whole, inviting other experts to prepare some recommendation that we as the ERN, as the EUROGEN, ITHACA, and ERKNet could be recommend. And one point, for example, is how to monitor this patient with ultrasound. That is a simple point, but could be very useful to define, because if we define a timetable for monitoring, as could be useful, in my opinion, to apply in every country, and without the concern of a different national health system, because we will have a European recommendation. And so I hope that we can follow activities after this meeting. I don't know if you have some questions, some concern.
You asked, sorry, Giovanni, was that to me? Sorry, about questions. I just want to, just while we're waiting, yeah, if anyone wants to ask a question, I'll just put it in the chat. If you can please type it in now. So we are getting on with time. So thank you.
Maybe I have a question for Giovanni. Thank you for your presentation, for Annalisa, Bruno, and Giovanni. Some patients with Down syndrome have urinary incontinence. And do you know why they have this type of problems? And can you offer some help for these children? What do you think about incontinence, urinary incontinence?
For all other, as we suggested as the ICI, the approach must be most conservative as possible, and one of the most important things for the continence achievement is the patients and to have time and to a bladder education that must require, of course, longer. And it's important that the families know this fact. And one point very important is to avoid to consider, as sometimes we see that is considered normal that the people with special needs, with some disabilities, has to use pads. It's not true, and they can achieve continence. And I believe that it's important to discuss and with the families and with patients too, of course, and their real desire, because sometimes it could be easier to reach to achieve continence, and also with the urotherapy. In some cases, we need to use a pharmacological treatment, and in some cases, we need to use more invasive treatment as a clinical intermittent catheterization. So the answer is that yes, it's possible to reach continence, and of course, is important to consider all the aspects a patient roundabout, and not only the specific urological aspect. Other point, as Bruno stressed very well, and thanks, and is relevant to avoid to miss some dysfunction on the bladder that could be at risk for the renal function, because one point is to have a loss of urine that impact on the quality of life only. Other point is to have urinary incontinence, but is related to dysfunction, void and dysfunctional, with the retention of urine, high pressure inside the bladder, and a mechanism that could be create renal failure. And for me, it's very sad to observe a patient with Down syndrome only when they have a severe bladder dysfunction, and they present a severe renal damage. And because at that point, what I can do is, in some cases, to require to clean intermittent catheterization, that in many situations is not accepted, of course, because patients with Down syndrome have a sensitive urethra, and to perform clean intermittent catheterization is very painful for them. And then I have to consider a mini-invasive treatment for bladder drainage, as the use of button cystostomy, that is very effective, but otherwise always a surgical procedure. And in other case, I have to perform a major surgery as a urinary derivation for using Mitrofanov. But in many cases, as I had to do, I only prepared the patient for transplantation, and is not a success. Maybe to recognize the bladder dysfunction many years before could be useful for all, and more satisfying also as a result of the treatment.
in such children, it may be interesting to do an uroflowmetry by physiotherapist to better understand what is happened and to treat the bladder dysfunction.
I totally agree.
Damien?
Oui, perfect. Thank you for this explanation on this proposition for patients. It's perfect.
As shown by Giovanni, it's extremely frequent and it's underestimated due to mental retardation. And we have to screen for such lower urinary tract dysfunction by a very simple question during the consultation. It's to know if there is incontinence, if there is polyuria, if there is if the child, if there is dysuria, and it has to be checked in every consultation. And if there is some anomalies, I think that uroflowmetry can be a good help by physiotherapists specialized in such troubles to prevent what has been described by Giovanni, the upper urinary tract secondary lesions. But sure, yeah. We have to be patient with these children with mental retardation and to accept to progress. Maybe in some cases slowly, and to work with physiotherapists specialized in such children.
Yeah.
I totally agree with you, also because, in my opinion, as you suggested, with a reduced economic cost, could be possible to use a questionnaire, to use a screener. For example, there is a very good screener of the ICIQ that is very few questions, and they permit to focus if there is present a voiding dysfunction or not. And we have used it, for example, in with patients, with people with a cerebral palsy, that again is another large group where we have a wide variability of dysfunction and also of mental impairment, and in many cases that we don't have a report by the family about the urinary tract infection, but we have a very light presence of lower urinary tract symptoms that when then selecting patient, we perform the uroflowmetry, then we perform the bladder kidney ultrasound, and we found a severe bladder dysfunction that has been missed. And unfortunately, I believe that this is very common in many countries. I don't believe that it's also a concern of Italy, but that in some group of population, a chronic patient, and they need control during time, but sometimes family misses something, but we as doctors miss to identify the light variation of the worsening. For example, one point very important, in my opinion, is in male the puberty, because with the prostate enlargement, it's quite common to observe in 1 to 2 years a worsening of the voiding function, and a system that has been apparently correct for many years before the puberty. After puberty, with the prostate enlargement, there is a severe worsening, and patient presented with renal damage, with infection, and for this reason could be important to use the screener diaries that are no cost, but of course take times and need someone that would like to use this time to help the patients and the families too. Thank you. Well,
I have a question for Bruno, possible. Bruno, you mentioned an increased level of creatinine in children. But what about adults? I don't remember a study about adults. And for you, is there a risk for long-term complications, kidney complications for these children with increased level of creatinine?
I think it's also underestimated, and there is no study in adults. Or more or less no. We know that some patients have severe renal failure, but there is very few data, only a few case reports, and there is very few data. I think chronic renal failure can be very few symptomatic, and I think it's underestimated.
Okay, thank you.
I think the important for me, the most important is to screen patients at risk of renal deterioration, and it's fully known now in the general population that prematurity, low birth weight, congenital heart disease are risk factor of delayed kidney function. Then we have, in my mind, we have to concentrate effort to these children. And the second point is the lower urinary tract dysfunction, which probably is cause some kidney dysfunction. And I think these children have already a lot of consultation, and you know that more than me, but we have to select what we have to do, and there is some very simple thing to do, as asking for signs of lower urinary tract dysfunction. It's very simple to know. I think sure there are some questionnaire validated, but I think it's easy, and it will be difficult to integrate such a questionnaire in usual follow-up of patients. But it's very simple to know if there is some incontinence, if there is some retention episode, if there is some dysuria. It's very easy to ask. And I think it's a good thing to detect, to screen these anomalies before to reach complex and very severe complication that has been described. There is a lot of case report of patients which are diagnosed at the end of the phenomena, with a fully deteriorated bladder and with severe and definitive kidney lesions. I think the problem was underdiagnosed since many years.
I must go because I have another meeting. I beg your pardon. And thank you a lot, because I have learned a lot of things about Down syndrome this evening. And I think we have a lot of things to study better, because we don't have enough data about this syndrome, and there are some aspects that has to be studied more deeply, I think.
But again, I agree with the American guidelines. We have to justify what we do. These children have already a lot of follow-up, which is very heavy, and we have to select what we want to screen.
Yeah, of course. But yeah. But perhaps we are studied a lot of the same things, and we are not studied some things that are issues for the patients. We have to see what, because Giovanni has said that he has some people coming that are too late for any kind of treatment. So that means that we are not studied the right things that we have to study, or we just don't do the exams, the follow that we need do not have people that has to be operated instead of treated. I don't know, but perhaps something is not going so well. Don't you think so?
Sure, but probably it's the few children or patients. We have to detect them before, but they are not a lot, as underlined by the American guidelines.
But the American guidelines are the same, are so valid and so good for European people. We have different population, and I know, for example, for Williams syndrome, they say that all the Williams people are very fat, but all the Americans are fat. And in Europe, it's not the same. So you have two different phenotypes. One is very fat and one is very thin. So in America, this is not true. So we have to reconsider sometimes what we take from America, because the population has a different phenotype from us. They eat a lot of junk food, for example, and that means that are more cholesterol, more fat, and so on. So I don't know if taking the guidelines from America without a revision is so good for European people, for all the syndromes.
I totally agree with you, Annalisa. I believe that we can maybe start from American guidelines, check to the American guidelines, but check where we have to ameliorate them and to consider the European situation, and using the where existing and the specific national guidelines, as could be, I know that, for example, that the French group has very good guidelines for different aspects, and it could be useful to check them, and maybe to transfer these guidelines to also best practice recommendation to other countries of Europe. So thanks for your time.
Thank you.
Thank you.
Thank you. Bye. See you next time.
Bye.
Thank you. Bye.
See you next time. Have a good evening. Bye.
Thank you all.
Bye.
Yes, everybody for attending. Thank you to the presenters. And so this will be recorded. So anybody who's I know some people had a couple of audio problems, so you should be able to watch it straight afterwards this evening. If you're using the same link that you joined with earlier, there will be a direct link sent out tomorrow to the recordings, not just for GoToWebinar, but also for our YouTube channel, where the video will be placed.
Oh yes, I've seen that we are in time, and if we don't have any other questions, maybe we can close. And thanks to all, thanks to the participants, and we will be in touch. And if someone would like to send to us some questions more, please send to us. And Bruno, Damien, thank you very much. And of course, Darren, thank you very much for the great support. Thank you very much to all. Bye. Bye.
Thank you. Have a good evening, everybody.
Bye. Thank you.
Bye.